So today we're going to be talking about basic emergency care. And basic emergency care is that care that we're going to give in those first few minutes of an emergency that will help stabilize a person until we can get more advanced care, or until we can get them into 911 if we're out in the community, or until we get our code team or our resuscitative team to be there. So it's that care we're going to give to keep the person alive and keep them from disability, hopefully, and to keep them from death until more help can get there. So when we're looking at basic emergency care, we are going to be talking about basically first aid care. And again, we said to prevent death, to prevent injuries from getting worse. So if you're out in the general community, we're going to activate 911 if we have an emergency. If we're in a hospital, we're going to use our emergency code system. So in a hospital setting, we wouldn't call 911, we are 911. But if we're in a nursing home, if we're working in a nursing home, depending on what the emergency is, it may be something that the RN can deal with and take care of on their own, or it may be something we have to call 911 and get them transported back to the regular hospital. Always remember in emergency care, we want to avoid contact with blood or bodily fluids. So in a nursing home or a hospital, obviously we have availability of gloves and emergency and personal protective equipment. But if we are talking about we're working out in the general community, that may not be the case. So you still always want to put a barrier between you and another person, whether it's a plastic bag or a sandwich bag, but something to keep that blood from soaking through. And yes, if something was bloody or had bodily fluids, you could use a t-shirt, but things could still absorb through that. So you would want something non-absorbent to protect your hands. And after we give care, gloves or not, of course, we're always going to wash our hands. So some basic rules for emergency care: you only do what you've been trained to do. Sometimes I teach first aid classes and people say, well, I saw on a commercial one time or a TV show where the person couldn't breathe and the airway was swollen, so they took a knife and they cut into the air pipe and they put a straw in there and they breathe through that. Can I do that? That's practicing medicine without a license, and that's going to get you in a lot of trouble. So you do what you've been trained to do and what is within the scope of your practice. Always try to stay as calm as you can. Very hard to do in an emergency, but try to stay as calm as you can. Try to give care where you find them. So when you find a person down, you don't want to move them unnecessarily. If someone's been in an accident and maybe they've hurt their back or they've hurt their neck, and now we pick them up and we move them to another area, we could actually make that injury worse. We're going to try to keep the person warm and reassure them. And we also want to promote the person's privacy and dignity as much as we can. Now, sometimes if you're out in the community and you're giving first aid care, that's really obviously going to be hard to do privacy. But especially in a nursing home and a hospital, we're always going to try to implement privacy as much as we can. If it's unsafe for you, if you are out in the community, and let's say there's a burning building, we aren't asking you to rush into burning buildings and pull people out. Wait for professionals that are trained to do that component of it before you just rush into a situation. So the chain of survival is something that the Heart Association developed, and the chain of survival says that if you should have early recognition and call for help early. So when you recognize that there's a problem, if you're in a hospital, we call their emergency code system. If we're in the nursing home, we're going to get that nurse, and the nurse will determine if it's something that the nursing staff can handle or if it's something we're going to need to call 911. If we're in the community, it will definitely be 911. Early CPR if necessary. Now, before you do early CPR, obviously, we do need to know the code status of our patient. So hopefully we knew that before this event happened. But if we don't, we would have to check with the nurse. We want to make sure that we're not resuscitating someone who wanted to be a do not resuscitate. Do not resuscitate means that if a person dies in natural causes, we're going to allow them to stay dead. We aren't going to try to revive them in any way. And in our nursing home setting, we will see a large percentage of our population are do not resuscitate patients. So if they do want to be resuscitated, though, we'll do early CPR and then early defibrillation. We're going to try to get them electrically shocked to try to get their heart going again if it's not working. And then hopefully early advanced care. So our paramedics will get there, or our code team will get there, depending on that environment of where we're working. Now the term sudden cardiac arrest, sudden means just what it sounds, suddenly. Cardiac is your heart, and arrest means stop. So it means a sudden stop of the heart. And so when the heart stops suddenly without warning, the person is not going to have a pulse, and they are not going to be breathing. Now they may have just an occasional gasping breath, which it's really rare and intermittent, and it's called an agonal breath, and that is not considered normal breathing. So if you have no breathing or just that occasional gasping breath and no pulse, we are going to consider them as being in a cardiac arrest situation, and we're going to do CPR for that person unless the person is that do not resuscitate. The term respiratory arrest, respirations are your breathing, so inhalation and exhalation. So respiratory arrest is the breathing has stopped. And so when the breathing stops, the heart can still continue beating for a little bit. So when a person quits breathing, that heart can potentially keep beating for 4 to 6 minutes. If we don't get them breathing again, the heart's going to stop as well, just from lack of air going to it, and then they'll be back in that cardiac arrest scenario that we were just discussed. So we want to do rescue breathing. If the person's not breathing, but they have a pulse, so they have a pulse, they're just not breathing, breathing's the only part we would need to do for them. And with adults, we give one breath every 5 to 6 seconds. And with infants and children, we usually give one breath every 3 to 5 seconds. Now, when you breathe for another person, everybody's lung capacity is a little bit different. So you're not worried about taking your full, complete breath of air and blowing it into another person. You only want to give enough air to see adequate chest rise. So you want to give enough air to see that chest going up and down, and that's really all you need. When we're breathing for someone else, we do want to use a barrier. So we would want to use a pocket mask, or we would want to do a face shield over their mouth, or hopefully if we're working in a hospital or a nursing home setting, we would want to use a bag mask valve system. So you always want to use a barrier. Now if you're in a home environment, then it will be a decision that you make for yourself. If you know the person, if it's a friend or family, you may choose to do mouth-to-mouth breathing without a barrier device. Even in the home setting, if it's something you're not comfortable with, you can always do just the compression portion of CPR. You can do compression only CPR if you don't have a barrier, and then when help comes and they bring that barrier, then they'll go into the compressions and the breaths. So mouth-to-mouth breathing can be done, so you can breathe your mouth over their mouth, pinch the nose, or you can do mouth-to-nose breathing. So let's say the mouth is wired shut and you can't, and they're not able, you can't get your mouth around their mouth because their mouth is wired shut. You would actually need to breathe through their nose. And for patients that have stomas, that have had tracheostomies and breathe through an opening that goes directly to the trachea, you can actually do mouth to stoma. For any of them, you would want a barrier device. So if they're not breathing and they have no heartbeat, we would go ahead and start CPR. So compressions are done when the heart stops beating. So if we have a pulse, we don't need to be doing compressions. If they don't have a pulse, we would do compressions for an adult. And generally the pulse that we're going to check is the carotid artery. So if you find that Adam's apple where you swallow and you slide over into the groove on either side of your neck, you have a carotid artery. And we check a person's pulse, so we would find their Adam's apple, we'd slide to the groove to find their pulse, and we would check that for 5 to 10 seconds. You want to check it for at least 5 seconds, but usually no more than 10. And if you don't feel a pulse in that time frame, we're going to go ahead and start compressions. Now compressions are done 30 compressions at a time out of a rate of about 100 to 120 compressions per minute. So we're doing 30 compressions to 2 breaths when we do CPR, but the rate, the pace of how we're pressing for them, it's nice and fast actually, and so it's a rate of 100 to 120 compressions per minute. We want to push hard, at least 2 inches in depth, and so you want to make sure you have a backboard behind them. So if I'm doing compression and they're in bed and the whole mattress is giving way with me with each compression that I'm doing, I'm really not doing as much benefit as I could. So you want a flat, hard surface underneath them. So if you're in a home setting and they're in a chair or on the couch, you'd want to drag them down to the floor if you could. If they're in bed and you're at home by yourself, if you can, you could drag them down to the floor. Otherwise, you would go ahead and do it on the mattress. And even though it's not going to be the best compressions that you could do, it will benefit them until more help comes and could help you get a hard surface underneath them. After every 30 compressions, we give 2 breaths. So your CPR ratios, we give for 1 rescuer adult CPR, we do 30 compressions to 2 breaths. For 2 rescuer adult CPR, we still do 30 compressions to 2 breaths. So whether you're doing 1-man CPR or 2-man CPR, we do 30 compressions to 2 breaths. If we're doing CPR for a child and an infant, if we're by ourselves, we do 30 compressions to 2 breaths. But if we have 2 rescuers for CPR for children and infants, we drop down to 15 compressions to 2 breaths. Defibrillation is something we want to do when a person's heart first stops beating. So if they go into that sudden cardiac arrest, you normally have electrical impulses that go through your heart. And these electrical impulses actually cause the myocardial cells in your heart to expand and contract. And so it will actually, normally you'll have these electrical impulses and it'll actually make your heart contract in response to it. When the heart first stops beating, a lot of times you will still have electrical current in your heart. There's just no rhyme or reason fashion into how it's working. And that's called ventricular fibrillation. And it causes the heart to quiver instead of contract. So as soon as a defibrillator gets there, defibrillation is the most definitive treatment you can do for this condition to actually stop that chaotic electrical activity, hoping the normal pattern will kick back on. So when an AED comes, an automated external defibrillator, first thing we always do is we power it on because it's going to start talking to us. It's going to tell us to attach our electrodes, to plug in the connector, and then it will go into an analyze mode. And when the machine is analyzing, nobody can be touching the machine or trying to do CPR. And then if it's in a shockable rhythm, it's going to tell you prepare to shock, stand back. Now some of them are fully automated. It's going to say shocking, prepare to shock, 3, 2, 1, and it just fires. And some of them it will tell you, press the button now. The shock is ready to be delivered. Press the button now. You actually have to press the button to deliver the shock. So regardless of which way, that machine's going to tell you what you need to do. So your first key to an AED is just turn it on and get that power going to it. Now, let's say you're doing CPR or you're doing rescue breathing or you end up using a defibrillator and the person seems to be revived. They're resuscitated. Their heart's beating again. They're breathing again, but they're not fully awake. If you have no reason to suspect head or neck injury, we can roll them either in a sideline position, a lateral position, or we can put them in a Sims position where we roll them on that side and flex the top leg so it actually kind of puts them half side, half prone position. But the recovery position, if a person is not fully awake but they're unconscious, the tongue can actually roll over the back of the throat, and the tongue blocking the back of the throat in is one of the number one things that will actually block an airway in an unconscious adult. So putting them in that recovery position will help that from happening. Plus, if they get sick to their stomach, this way it comes out the side of the mouth instead of being sucked down the lungs. Hands-only CPR, we said, is that option if you have no airway, if you have no barrier device, and you're not comfortable breathing for the person. You can do just the compressions. And you know what? If it's a witnessed adult arrest, it's actually been shown to be very effective. For children, in all honesty, it's best to breathe for them in addition to the compressions. But if you're not comfortable breathing for them, it is better than doing no CPR for them. Now, choking, we talked a little bit about choking when we talked about our safety chapter, but with choking, we normally do abdominal thrusts for a conscious adult and child victim. So child from 1 and up. Infants, we do it differently. But from 1 through adulthood, we do abdominal thrusts where you find that belly button and you bring your fist, thumb side in, right above the belly button, other hand over it, and it's an up and inward motion. You're going up and in. So it's almost like a scooping motion that you're doing. And it's a very forceful movement. Each one is its own separate movement, like that's the one that's going to get the object out. And you're going to do that until that object comes out or until they pass out from lack of air. Now the problem we have in the nursing home is unfortunately not all of our residents can stand up like this. So if they're choking, if they're in a wheelchair, and you may be able to get around the wheelchair and get around their stomach and do this, but if you can't, and they're in a chair, for instance, you could actually drag them down to the floor and modify your abdominal thrust, where you just kneel beside them and do this part of your hand right above the belly button, and you're going up and in this way. So sometimes we have to modify that a little bit for our elderly residents that aren't standing, obviously, when they're choking. If you are choking and you're by yourself, this shows you right here, you can actually throw yourself over a chair where the chair hits you right about there, and a lot of times that will dislodge the object. And for children, we do a series of 5 back blows and 5 chest thrusts. So you hit them right between the shoulder blades with the heel of your hand 5 times, and then you turn them over and you do 5 chest compressions to help move that object out. Now once the person becomes unconscious, then we go into a CPR technique. Poisoning, if you are taking care of someone who has poisoning, or they've gotten into something, whether it was accidental or whether it was intentional, and some signs of that might be burns or stains on their clothing, empty drug bottles, vomiting, shortness of breath, which is dyspnea. So we said DYS in front of a word is difficult. PNEA, pnea, is the root word for breathing, so dyspnea is difficulty breathing, or drowsiness or confusion. We want to call 911. And we also want to call poison control. So with poison control, if you tell them what they were exposed to or what they got into, they will tell you best first aid care to give that person until more help comes. So if the poison is on the skin, we want to wash it off really good with fresh running water. If the poison is in the eyes, we would rinse it out for like 5 to 10 minutes. And then they still need to go in, obviously, and get that checked out. A heart attack, another name for a heart attack is an MI, a myocardial infarction. And so a myocardial infarction or a heart attack occurs when part of the heart muscle does not get blood and oxygen. And we'll be talking about heart attacks and strokes in a lot more detail in a later class. But when part of the heart muscle isn't getting blood and oxygen, that part of the heart muscle is going to die. Now, just because a person's having a heart attack, it doesn't mean their heart is going to stop beating. That sudden cardiac arrest is a complication of a heart attack. It is possible when the person has a heart attack that their heart just stops beating. But some people have heart attacks and will stay awake and alert through the entire process. But symptoms usually of a heart attack are chest pain. The pain may radiate. That means it may travel. It may go from the chest, and it may go up the neck or down the arms or through to the back. Shortness of breath, which is abbreviated SOB, so shortness of breath, where they look like they're winded, like they're having a hard time getting their air in. Diaphoresis, which is a fancy name for sweating. And nausea and vomiting. They get sick to their stomach and possibly throw up with it. Now, you don't have to have all of those symptoms. Some people just have chest pain. But women sometimes, especially your elderly women, they tend to present, instead of having chest pain, a lot of times they just have shortness of breath and sweating for no reason, or they might have some jaw discomfort and diaphoretic. So they don't have to have all of those symptoms for you to think it's a heart attack. If you think a person's having a heart attack, sit them down, make them comfortable, loosen any tight clothing, and make sure you call 911. Okay, get them help. Now, the term hemorrhage means an excessive loss of blood in a short time. So hemorrhaging is severe bleeding. And it might be internal, where it's happening inside the body and you can't actually see exactly where it's coming from, or it might be external, where it's bleeding that's actually coming out of the body. So if you think they're having an excessive loss of blood in a short time, we would call 911 if we're out in the community, or probably also in the nursing home. And if it's somewhere we can see, we want to apply pressure. So if someone is bleeding, we want to take some nice clean gauze, and we want to we hopefully have gloves on, and we put direct pressure directly over the wound, nice and firm. Okay. If they still continue to bleed, you don't want to pull this stuff off. You want to add additional bandages right onto that area. If there's an object in the wound, so let's say they have a piece of glass in their arm, or a piece of glass, or a wound that has a stick or something in it, don't remove it, because a lot of times that object is actually keeping the wound from bleeding too much, and you go and remove the piece of glass, or you go and remove the stick, and now you're going to be dealing with severe bleeding in addition to a wound. So you do want to make sure that you keep it, nice firm pressure on it. If it just keeps bleeding, you want to go ahead and you want to make sure that you call 911. Now, tourniquets are when you tie something so tight, so you go 3 or 4 inches above the area where it's bleeding, and you tie an object so tight around it that you cut all circulation off to that area. And that will definitely take care of the bleeding, but the problem with that is if you you cut off the circulation entirely above that spot where it's bleeding, you're also cutting off the oxygen supply to the tissue. So if it's left on too long, potentially they could actually lose their arm. Now, let's say they're bleeding so severely and it doesn't matter what you do, and you're applying pressure and you're a long way from help, you may have no choice but to put a tourniquet in. But usually, most of the time, direct pressure will take care of most bleeding issues. The term shock occurs when organs and tissues do not get enough blood and oxygen. So remember, your oxygen binds with your blood, with the hemoglobin in your blood, and it gets carried throughout your body. And so when the organs and tissues are not getting enough blood, it can go into shock. Now, there are multiple different types of shock, but I'm going to talk about 3 of them because I think they're fairly important, and I want you to learn the difference between them. Hypovolemic shock. Hypo is low. Hypo is low, volemic is volume. So low volume shock. So we're talking about that person is hemorrhaging and they're bleeding and all their blood is leaving their body. Or maybe they're just so dehydrated that they don't have any fluid left in their system. So there's hypovolemic shock caused from low volume. Anaphylactic shock. Anaphylaxis is an allergic reaction. So anaphylactic shock is going into shock from a severe allergy. And septic shock is going into shock from a severe infection. So regardless of which type of shock it is, the symptoms are pretty much the same. Blood pressure drops. So when a person goes into shock, their blood pressure lowers. They have low blood pressure, their heart rate goes up. So their heart rate speeds up, their blood pressure drops. Rapid respiration, so their breathing picks up. Cold, pale skin, they get kind of cold and clammy. Restlessness, because they're almost kind of confused and restless, because they're not getting enough oxygen up to the brain. So those symptoms are the same, whether it's hypovolemic shock, anaphylactic shock, or septic shock. Now, septic shock, which is caused by an infection, usually you'll have fever with it as well. So when a person is having shock, and so they seem confused, they're restless, they're agitated, and that's not normal for them. And their skin may be pale and cool, and their breathing is picking up, and their heart rate's picking up, and their blood pressure is starting to drop. We need to get that person help right away. If it's something, if it's something that we can fix really easily, usually they'll do really, really well. If it's something where we can't take care of it, or we don't recognize what's happening to the person and it really progresses, eventually that heart rate that's sped up can slow down and stop, the breathing can slow down and stop, and your patient can die. So it's something we want to be very, very careful with. Fainting is a sudden loss of consciousness from an inadequate supply of blood to the brain. So the person just temporarily passes out because they have a lack of oxygen going to the brain. It can be from severe dehydration, and then they get up too suddenly and the blood just kind of drops down into their legs. It can be because they were bleeding. It can be from any type of illness or injury. Actually, the person can faint. Some people faint at the sight of blood, even if they're not injured. Some people faint when they're pregnant. But when a person has a temporary loss of consciousness from inadequate supply to the brain, the first thing you should do is lay them down. And if there's no head or neck or leg injuries, if there's not injuries involved, you can elevate the legs a little bit. That'll take that blood that's pulled in the legs and try to get it back up into the main part of the body where they need it the most. Generally, they'll usually wake right up after a little bit. If they're not, obviously, we're going to make sure we call 911. The term stroke, the official or medical terminology for the stroke, is a cerebral vascular accident, or CVA. And symptoms of a stroke is sudden confusion, hemiplegia. Hemiplegia is where half of the body is paralyzed. So half of the body is paralyzed. Slurred speech, that's a fancy word for slurred speech, is aphasia. Double or blurred vision, severe headache, or an unsteady gait, and gait like a walking gait. So I would highly recommend, and we'll talk again about this later when we talk about strokes in more detail, but I would recommend that you remember the terminology be fast. And be fast, B stands for balance, so if their balance and coordination is all of a sudden not there where it normally is. Eyes, if their eyes can't track you, they can't follow along with you, or their eyes aren't like equally their pupils aren't equally reacting the same. Their face, you have them smile, and if only one side of the face goes up and one side won't go up. Arms, you have them hold their arm out, and if one side is just starting to drift. Or speech, they can't get the words to come out right, or they know what they want to say but that won't come out right, or the words come out right but they make no sense. So either way. And then the T stands for time. You want to know the time of when they were last known to be normal. We have treatments and procedures for stroke, but many of them are time dependent. And so they have to get to the hospital within a certain amount of time, and they have to get treatment within a certain amount of time at the start of the symptoms for the treatment to benefit them. So that's why we want to know the time. Seizures, another name for a seizure is a convulsion, and convulsions are sudden violent contractures or tremors. Epilepsy is a brain disorder that causes seizures. So if I knew a patient had epilepsy and they have a seizure, and as soon as the seizure's over, they wake right up and they seem to be doing okay, I am going to let the physician know, but chances are we probably aren't going to do much different with it. But let's say I don't know the person has epilepsy, or the person just had a head injury and now they have a seizure. I would always, or they got hit in the head with something, they fell and hit their head, I would want to make sure that I again, would call 911 for that, unless I was already in the hospital for that. So with the seizure, because they're having these violent contractures or tremors, one of the first things you want to do is you want to protect them from hazards. So in this picture I'm showing you right here, let's get that chair out of the way. Let's get the noodles in the jar out of the way. If we can, let's tuck something under the head so the head's not banging and hitting on the ground. We do not need to stick anything in the mouth. We do not need to hold the tongue. We do not need to stick anything on the tongue. Okay, just protect them from hazards so they don't hurt themselves when they're jerking. And then after the seizure is over with, then we're going to check them. Are they breathing okay? Are they starting to wake up? We can roll them on their side if they're not fully awake, that recovery position, so long as they're breathing and their heart's beating. We just take a look and make sure we don't see any other injuries going on. So treatment for seizures, here we go, lower them to the floor, protect them from hazards, protect the head, don't put anything in the mouth, don't try to stop the seizure, don't try to physically hold them down and stop the seizure activity. You want to note the time, because they're going to want to know how long the seizure was, and after the seizure's over, make sure they're breathing and waking up okay. As far as concussions go, a concussion is caused by a bump, or that should say blow, not bow. So caused by a bump or a blow to the head. Symptoms can last from days to weeks and can impact thinking, physical function, mood, sleep. Get them help. If a person gets hit in the head or a blow to the head and now they've got a headache that's not going away, or their headache keeps getting worse, or their coordination is off, they're starting to feel nauseated, they're vomiting, they're drowsy, or they might have seizures or convulsions, their behavior seems abnormal, they need to go get help. They need to get looked at. And heat-related illnesses or injuries, there's heat stroke, there's heat exhaustion, and there's heat cramps. So heat cramps is the more mild one, and usually we see that from really heavy sweating during exercise, and the person gets a little bit dehydrated, so they start having muscle cramps and muscle spasms. Usually they just need to get cooled off and get lots of good fluid in them. Heat exhaustion is usually caused by really heavy sweating to the point where they're dehydrated now, and their skin becomes cold and pale, their heart rate gets really fast, they start feeling nauseated, vomiting, dizzy, they're tired, they're weak. Very, very important that we get them cooled off as soon as we can. So putting, cold towel, dipping towels and water and draping them over them, putting cold packs around their neck and under their arms. We've got to get the body cooled down. And then heat stroke, the body temperature can actually go over 103 degrees. The skin now is red and hot and dry. They may have really severe headache or pulses really, really fast and just kind of boundingly strong. They're usually dizzy, lightheaded. And if we do not get that temperature cooled down immediately, they can have serious damage to their brain because of that. So we've got to get them cooled down. If I was outside and I was near a lake or a pool, I'd actually put them in the water or put a hose over them, get towels and get them wet and drape them in wet cloths. Get cold packs around that neck and the groin area and the underarms. That'll help cool the body down a little bit quicker. In a hospital, we actually have a cooling blanket. It's called a bear hugger, and we can actually put cold through it or we can put heat through it depending on what we need, and we can use that to start cooling the body down as well. But you've got to get that body cooled down. Cold-related illnesses, a fancy name for that is hypothermia. So hypo is low, thermia is temperature, so an abnormally low body temperature, usually less than 95 degrees, and that they may feel cold and pale, their speech may be slowing, their heart rate and breathing slows down, they might have loss of consciousness. So if a person's really, really cold, we need to get them warmed up. So we can put warm blankets on them, we can use that bear hugger I was talking about and put warm heat through it and get them warmed up that way, but we need to get their body warmed up. Now, if a person if part of the body has gotten so cold that it looks like it has frostbite, and when a person has frostbite, there's injury to the skin and the underlying tissues, they actually freeze. We actually need to warm the body up slowly. We don't want to, we don't do massages. We don't do a lot of massages to frozen extremities, because if the blood cells in there are frozen, it can actually break the blood cells in there. So we do want to warm them up slowly and let it basically unthaw. And burns, there's first-degree burns, second-degree burns, and third-degree burns. First-degree burns usually impact just the top layer of the skin, so the epidural layer of the skin. Usually the skin is red and hot and dry. Just get them out of the heat, cool it down, cool water. You can usually, we normally say don't use home remedies for burns, but if it's just like a sunburn, basically, you can usually use an aloe vera gel or any first aid type of burn gel. It's fine. Second degree burns, usually you've gone through the top layer of the skin, so you've gone through the epidermis and you're now in the dermal layer of the skin, and so generally it'll start blistering, and those blisters can pop open, and those are usually extremely, extremely painful, and they get infected extremely easy. So we want you to cover it with something, we prefer something sterile, but if not, especially very clean, cool, moist coverings, and just go ahead and bring them in and get it looked at, okay? They usually need some burn ointment for them, but it is a prescription medication. We don't recommend home remedies. We don't recommend aloe vera gels, or I've seen people come in with mayonnaise on a burn. I've seen people come in with toothpaste on a burn. It is a pain in the butt to try to clean that out of a burn. So we don't recommend home remedies. Third degree burns can go through the epidermis and the dermal layer. It can actually go all the way down to the muscle. And so third degree burns are, of course, the worst type of burn that a person can have. But sometimes people complain of more pain with a second degree than they do a third degree, because the third degree, the nerve endings are actually burnt. So we want to remove them from the source. We want to stop the burning, remove jewelry, because a lot of times burns will start swelling. Cover it with as clean as possible. Don't put anything dirty on a burn. Your skin is your first line barrier to infection. If you put something dirty on it, you're just going to open them up to infection. Don't use home remedies, and then again, there's a good chance they're going to go into shock, so start thinking about shock. Keep them a normal body temperature, talk to them, reassure them, keep them nice and calm, and if there's no injuries to their head, neck, legs, anything like that, you can raise the legs up a little bit so it brings the blood pool back up into the main part of the body. So that is going to end our section on emergency.